Okay. Well, we'll get cracking on then. So this is the basic structure of how this is going to work. So if we start with the antenatal examination, just like in any exam, you would start with basic introduction of yourself. Make sure it's your full name and the role. Depending on the year you're in, you're either a junior doctor in the OSCE scenario, or final year student, or a GP, or like things like that. And then you make sure to confirm patient demographics and explain exactly what you're going to do. So I've put a small section here just in case you guys wanted something to help you in the explanation of the procedure. And then with the antenatal exam, because they have to bear their abdomens, you always mention a chaperone. And in almost all situations, you will have a chaperone, especially while in OSCEs, your examiner is one. And when you gain consent, you ask the patient to empty their bladder before examination, and this is just so that you could feel better for the baby, and also to get a urine sample, so you do a dipstick on it. So generally you start from the bedside, and you ask the patient if they're in any pain, and you also observe if they're in pain or showing any obvious signs. And then you start with bedside things, if they're having any medications with them, or even when they walked in. Obviously in OSCEs you can't see them walk in, but in real life you would see how they walk in, or if they're having any obvious difficulties coming in. And then you look at their hands, so temperature, any obvious pruritus or erythema. This is a picture of pruritus. Then you go and check their cap refill for any signs of cyanosis and subperipheral cyanosis. Then both of the radial pulses. On the face, you could see jaundice, melasma, which is shown here. This is like a normal sign in pregnancy. And then conjunctival pallor. Then you go down to the abdomen. And obviously within the OSCE stations, it depends. Sometimes when you start from general inspection and hands and face, the examiner will be like, no, skip that, just go directly to the abdomen. So it depends on what they want you to do. But you again start from inspection, and you position patients generally at 30 to 45 degree on the bed, because it's difficult for them to lie flat on the bed. And you look for any signs of abnormal abdominal distension, which could be some obstruction or ascites, or they could tell you they feel more bloated or something abnormal themselves. Then for obvious scars, so for previous C-section, which is transverse suprapubic, then any laparotomies, laparoscopic scars and things like that. And some normal signs in pregnancy, which are basically stretch marks. These ones, the gravidarum ones, are pinky. So in this pregnancy, and if there are other ones which are slightly white, then they might have had previous pregnancies, and this is an indication of all stretch marks. You see the linea nigra, umbilical inversion, which usually happens after 30 weeks, and some dilated superficial veins, which you could or could not see. And after 24 weeks, sometimes you can see fetal movements, but then again, you ask the mother for that later on. So how do you start? First is fundal height. So you tell the patient, I'm going to feel for the top of your womb now. And what they say is you have to feel it with the ulnar border of your left hand. So if this is the abdomen, and this is the top, and this is the pubic symphysis. So you go like this, and you start feeling and palpating for that fundus. And it's usually like a line that you can kind of feel, but it's difficult sometimes to feel it just like going with your ulnar border. So I tend to palpate quite deeply sometimes to feel for it. And the picture here is just a nice guidance on whereabouts you could feel potentially the fundus during like each week of gestation. So once you feel that, you go down and feel for the pubic symphysis, and you let the patient know that this could be quite uncomfortable. So you, because you have to press and you're quite low. So just let them know, signpost, and then you place a tape downwards just to get rid of any bias or anything. And you start with the top. So you put a 1 on the top where you feel the fundus, and then go down. And then when you're done measuring it, you then turn it over and check what's your measurement. And plus or minus 2 centimeters are all right according to the gestation age. So on palpation, then again, you check for fetal lie. So after the fundal height, you check fetal lie. You say, I'm going to feel for your baby now. You place both of your hands on each side of the uterus and just apply pressure. And it says apply gentle pressure, but sometimes students can what's happening?
Sorry, someone's just joined.
Yeah. Okay. So sometimes what happens is every examination says apply gentle pressure, but you look at the mother's face and you ask her if she's in any pain, or you can see it. And sometimes I've had patients tell me that I don't press hard enough. So make sure that you're not too gentle, but at the same time, don't be too hard and poke things, you know. And so when you apply pressure, you hold with one hand and apply pressure with the other one like this, and then do the opposite. And so you feel, you could feel the back or where exactly they are, depending on how soft the parts you're feeling are. And fetal presentation, again, are they longitudinal? Are they oblique? So do they longitudinal can be head down or feet down. Oblique could be any position, and then transverse. So you feel that, and that's the fetal presentation. And as I mentioned, watch the patient face throughout your entire palpation and examination and everything. And when the patients are quite far in their pregnancy, which is like above 36, 37 weeks, you could feel for the presenting part. The presenting part is basically what's exactly low in the pubic symphysis. So mostly we expect when they're closer to delivery, the head to be lower in the pubic symphysis. So you mentioned, I'm going to press harder now. If this is painful, please tell me, because you will definitely be pressing quite hard to feel exactly how much of the presenting part you can feel. So as I wrote here, head, when you feel head, it's basically hard, narrow, and it's round. If you feel the bottom, which could be breech presentation, it's soft and broad and it's not very defined. And in terms of engagement, so when the obstetricians talk about engagement, is basically how much of the head is basically divided into 5 parts. So that's why you talk in fifths. So 5/5 of the 5/5 of the head palpable is fully engaged. And if it's 5/5 of the engagement means like you cannot feel anything. But if you feel less than or equal to 3/5, that means the head is engaged. So when it gets fully engaged, you won't be able to feel the head, basically. And peripheral edema, signs of peripheral edema. Edema can be normal in ladies, of course, pregnant ladies, but just ask them like if they're felt abnormally edematous, like their fingers, they had to take rings off and things like that. So afterwards, for auscultation, what you do is you listen to the baby's heart, and you obviously consider where the baby's lying, and you feel for their shoulder. So whichever shoulder is on top and you feel, you go that way and just palpate, and that's the best way to feel, to hear the heart, to where the pinar should be placed. So you place the pinar stethoscope. I don't know if any of you guys have done this before, but it's basically like a tube plastic thing, which actually is quite a simple instrument, but it really does help you out in listening to the heart. So you place the bell of it and then make sure that you take your hands off and just put your ear on it, on top of it. And this is done after 24 weeks. And you do a Doppler ultrasound earlier when they want to hear the baby's heart, or if you think there's some issues, or they're going into labor. So yeah, this is just an ultrasound machine. You guys know how this works. You do the same thing, put the probe and gel on the anterior shoulder. But make sure that, when it takes you more than a minute or two and you still cannot find the heartbeat place, just so that you won't worry the mother. And we're all students. It's quite difficult sometimes when you have no experience. Just let go and be like, I'm unable to find exactly the right place for me. Don't worry. The doctor will recheck again for you, because the mother can get quite worried if you're there just poking and not being able to hear any heartbeat. And then, of course, after you're done, you thank the patient, you allow them to dress, and you dispose of every PP. Nowadays, obviously, it's going to be more than usual. Make sure you wash your hands again, and then you summarize your findings. And again, I've put in here how you actually summarize your findings. So you say, for example, today I examined Miss whoever. On general inspection, the patient appeared well and alert. She was comfortable at rest. There were no signs of any breathlessness, or no evidence of any obvious jaundice or conjunctival pallor on the face and peripheries. CRT was within normal range. And then you mentioned the height, which is in keeping with gestation or not in keeping if it's smaller or bigger than 2 centimeters. And then you mentioned the fetal position, the presentation, how much you could palpate. And then you say, to complete my examination, I would like to do X, Y, and Z. And usually what you do is the investigations. So it's blood pressure, urinalysis, speculum, and abdominal ultrasound if needed, or if there's like any abnormal indication for that. But mainly, even when you're doing the examination, they could ask you to do blood pressure, and it's most likely going to be with a manual machine. So make sure you guys are comfortable with them, because even in real practice in obstetrics, they tend to use mechanical blood pressure measuring machines, because they think it's more, it's more accurate. Or they could ask you, instead of blood pressure, to do a urinalysis just to check for proteins or nitrates or anything like that. So those are the 2 things you should keep in mind for the OSCEs. And now we go on to the obstetric history. Okay, so if I go back, could you guys tell me what problems pregnant ladies usually present with? Just type in anything. Okay, spotting. Nice. Anything else? Come on, guys, there isn't many of us. Yes, exactly. Feeling faint. What else could they present with? Worried about not feeling the baby's movements? Yes, that's great. Well, all right then. So, okay, great. So what happens is, in obstetric history, mainly people present with, well, pregnant ladies could present with anything, but it's mostly abdominal pain, bleeding, discharge, fetal movements, nausea, constipation, skin changes, hair changes, and things like that. But if we bring it down and make it more structured, so when you're taking an obstetric history, you start with introduction again, and you explain what you're going to do and that it's not going to take a long time. And then the presenting complaints. So what usually happens is 4 Ps. So the main obvious presenting complaints. So there's pain, there's PV bleeding and PV discharge, and then there's everything that could go wrong in pregnancy generally. So that's like fetal movements. Nausea and vomiting, edema, headache, visual changes, pruritus, which could be a sign of bile acids and things like that. And then just systemic ones. You always ask for systemic systemic symptoms. So like abnormal weight loss, change in appetite, fevers, rigors, things like that. And when you're done asking for all the presenting complaints, so because they don't always come just with one thing, you make sure that you get all the time frames correctly. So when did it start? How long has it been? Is it always there? Is it not? Is it intermittent? And things like that. And then with pain, you always go through Socrates. So that's site, onset, character, radiation, associated symptoms, time, exacerbating or alleviating things, and then the severity of it. So they rate their pain up to 10. And then with PV bleeding and discharge, you make sure to ask what type it is. So is it bleeding? Is it discharge? What color it is? And how much? In terms of quantity, you ask them in terms of how many pads do they have to change, or tampons, or things like that. And then odor, obviously, does it smell funny? Like, because if it looks different, how does it smell? Do they see any clots in there? And then you make sure to summarize everything at this point. And why at this point specifically? Because most of the information they're going to give you is going to be in presenting complaint and history of presenting complaint. And just to make sure you haven't forgotten to ask something else, you summarize, and then you can be like, is there anything else that I haven't asked you that you've been feeling for this period of time? And then you ask them, you ice. Is there anything in particular that you're concerned about? What do you expect from me or from us? Because it is very, very, very important, especially in pregnancy. And usually how they would give you a patient, they wouldn't just be calm there, right? So pregnant ladies with any issue, they're super anxious. So it will be a very anxious person or an angry person. So you'll have to ask them how they feel and what can you do for them, just for them to calm down and start to build that rapport with you. So when you've done this, you go to current pregnancy. So how is their pregnancy going? And how many weeks they are, their gestation, and do they know if it's a single baby or is it twins or even triplets? And then you ask, when was their last menstrual period, just so you can count the expected delivery date, which is EDD. So EDD is last menstrual period plus 9 months and plus 7 days. So that's how you calculate their expected delivery date. And they usually deliver in about plus or minus 2 weeks. And that's normal. And you make sure to ask them. This is a very important question. Like, how do you feel about this pregnancy? Because sometimes it's not planned. Sometimes everything that they feel in terms of support and their home comes up after this question. So they could tell you, this was planned and I'm happy, or this wasn't planned and I'm thinking what to do. And depending on how far their gestation is, they might want to terminate the pregnancy and things like that. And then scans and screening results. So up to this date, have your normal screenings and scans have been normal? Have you had them? Which ones have you had? Make sure you guys are comfortable and you know the normal pathway for like what weeks they get which screening and scans, because this is important. In OSCEs, sometimes, for example, in penultimate year or final year, they could just ask you to, so they could present you with a pregnant lady with her scan results, for example, Down syndrome, and they could ask you to explain the results of that scan to her, and then also discuss some management plans on what should be done next. So it's really important that you guys are comfortable with the scans and how to interpret the results. And then you ask them, have they had or are they having folic acid in the first trimester? How do they plan to deliver the baby? It can be in the labor center. It can be a water pool. It could be with epidural, without, things like that. Or do they know that they need a C-section and why? Things like that. And problems in admission during this pregnancy, have they had any issues, or have they been admitted during this pregnancy? And then you move on to general obstetric history, and I tend to remember it with GMC. So starting with G, it's gravida and parity. So if you guys aren't familiar with this, gravida means the number of times a lady has been pregnant, and parity means going through giving birth, the process of giving birth after 20 weeks. So if it's a viable pregnancy, basically, right? So if they were, for example, pregnant in the past, pregnant once, right, gravida 1, but it was a miscarriage or it was a termination, the parity would still be 0 because it wasn't a viable pregnancy. But for example, if they had 2 pregnancies and they have 2 children, then it's going to be gravida 2, parity 2. Okay. So after G, you ask for C. So do they have any children? And then if they do, how many, their ages, their birth weights, types of deliveries. So basically anything you could ask about the previous deliveries is helpful, just to know if there were any complications, and do we expect them in these pregnancies? And ask about type of conception. So was it natural? Was it via IVF? How long did they try? Things like that. And M, because it's quite a sensitive question and everything, you signpost. So you could say, I will now ask you more detailed questions, which can be upsetting. So please feel free to stop me at any point. Or you could formulate it in your own way. It doesn't matter. As long as it feels natural and you're showing empathy, it's all good. So then you ask, have you had any miscarriages? So any ectopic pregnancies, terminations, stillbirths? And at what age? So what was the gestation age when you had miscarriage? So how many weeks were you? And then how was it managed? So for example, for terminations, like, did you just take a medication? Was it surgically removed? Miscarriages as well. Did you need to go for further procedures? Did you have to go to the to get cleaned and things like that? You need to ask. And then gynae. So I know this is an obstetric history taking session, but in every obstetric history, there is some gynae bit, and in every gynae history, there is an obstetric bit to it. So they always go hand in hand. So you do ask about gynecological stuff. And the main ones, I think, are cervical screening. So all the smear tests up to now, have they been normal? And have you been like going to appointments? And then any previous STIs, malignancy. But then you if you have time, it's good to ask, but if you don't have time, please ask other things. But like their menstruation apart, like outside of pregnancy, how was it before? Was it regular? When did they start? Things like that. And what forms of contraception do they use usually? Because, for example, if it was unplanned pregnancy, then contraception use is quite important, just to prevent further unplanned pregnancies if they want a contraception, you know. And then in terms of past medical history, you ask them, do they have diabetes, hypothyroidism, any blood-borne viruses, epilepsy, and any venous thromboembolism risk factors. And then in terms of medication history, it's always important to ask allergies in any history, basically. And then are they taking folic acids? Do they need any antiemetics, iron supplements, any antacids, aspirin? And then you make sure to ask if they're on any of these medications, because they could be teratogenic and they should be stopped. So I've just listed some on here, just for you guys to remind yourself. And family history. Family history is important in terms of, for example, the patient's mother could have gone through preeclampsia, or they've got diabetes, or they had twin births, so she could give birth to twins as well. And then any genetic conditions like cystic fibrosis, sickle cell, thalassemia, and things like that. And then we go on to social history. Social history is particularly important with pregnant ladies because you always have to ask, what do they do? Where do they live? Do they have enough support? So who lives with them? Are they married? Are they not? Do you think they're supported? Is there any form of abuse? And of course, from patients and from consultations, you could kind of, it's judgment based. So if patient is giving some signs, if she's hesitant, if she's quite unsure, quiet about things, or she, you could pick up on some cues like that, body language, and just lead your conversation towards that way. So you could ask her, is there any chance of abuse at home? Like, do you work? Who's the so does your husband work? Are you having any financial issues? Is everything all right? So was this a planned pregnancy? Are you happy about it? Things like that. And if they do need any form of support, you need to be ready with some suggestions during OSCEs. And then you ask about their diet, how active they are. Do they smoke? Do they drink alcohol? Do they do any drugs and things like that, which are generally asked in any consultations. And then you end your consultations by again summarizing and make sure you get really sleek in summarizing your histories, because consultants and examiners generally don't like you waffling around. So you could be like, today I met Mrs. X, a 34-year-old lady who is, for example, 30 weeks pregnant. She presented with back pain, which has been going on for so and so long. She associated with, for example, nausea, vomiting, hematuria, or something else. She has this family history. She's otherwise fit and well. She's taking this medication. She works as this. She lives with her husband. She's fully supported. No nil history of smoking or alcohol use or any drugs. So my impression is whatever you give your differentials, and then they could ask you the next step. So in terms of investigations or management, and that depends on what level in med school you are.
Thanks for watching. Don't forget to like and subscribe. If you're watching this on YouTube, head to our website to watch the next part. If you're already there, just mark this part as complete.